Dr. Xandra Petway, and you're watching Dr. Petway and Friends. And today, my very special friend is Dr. Andrea Hayes. Hello, Dr. Hayes. How are you today?
Great. How are you?
I'm fine. Thank you so much for being a guest on our show.
Well, thank you for having me back.
Great. Dr. Hayes is an endocrinologist, and I want you to tell us what an endocrinologist does and the type of illnesses that you treat.
Well, endocrinologists specialize in the glands of the body, and the glands are structures that secrete hormones, and hormones are chemicals that travel in the blood to other places and cause certain metabolic actions. The most well-known endocrine problem is diabetes. The pancreas makes insulin, and a lot of times that hormone is deficient or doesn't work so well, and that's what causes diabetes.
Okay. What about some of the other glands that you deal with, like the pituitary, the adrenal,
Exactly.
the parathyroid?
Yeah. Well, the pituitary is located at the base of the brain, back behind the eyes, and it's the master gland in the body.
Okay.
It sends signals to lots of other endocrine organs to cause those organs to secrete more hormones. And then there's a feedback loop where the hormones travel back to the pituitary to regulate the production of those hormones. The thyroid sits here in the neck. We talked about that before, the butterfly-shaped gland that controls metabolism. Yes. There are also 4 glands that sit behind the thyroid called the parathyroid glands, and they're about the size of a pea. There are 4 of them, and they control blood calcium, how much calcium's in the blood, how much is in the bones, how much is absorbed from the food we eat. And then we have the sex organs, the testes in men and the ovaries in women. Those are endocrine glands. And then the adrenals that sit on top of the kidneys, and those make certain stress hormones and certain hormones that have to do with salt and water metabolism.
Okay, sounds great. Well, let's start with the pituitary. What type of illnesses can occur when the pituitary isn't functioning properly?
Well, the most common problem is a pituitary tumor. Most of those are silent. They don't cause any symptoms at all. If a pituitary tumor got big enough, it could cause trouble with vision and headaches. The most common visual symptom would be that people are losing their lateral vision, like out to the sides. They might have trouble seeing stop signs when they're driving. But most pituitary tumors are asymptomatic. They don't cause any symptoms at all, and a lot of them are noted incidentally when somebody has a scan of the head for some other reason.
Okay. What about something like acromegaly? Do you treat that?
Yeah, there are about 6 different syndromes that certain hormonally active pituitary tumors can cause, and acromegaly is one of them. That's when the pituitary makes too much growth hormone. And when people are already adults and their bones have already fused together, growth hormone causes enlargement of structures that we already have, like our bones and joints and the heart. It also causes high blood pressure. The face can get a certain look where the forehead is bigger and the mouth and the teeth get widely spaced. Those are symptoms of acromegaly. That's not a very common pituitary tumor, but it is one that is classic, and when you see somebody with it, you pretty much know that that's what they have. It takes a number of years for those features to occur, so it's usually diagnosed after a while, after it's been there for a good while.
How would you treat acromegaly?
Well, the primary treatment of most pituitary tumors is surgery. So that would be the first step, and then there are some other medicines and radiation therapy that can help if the syndrome is not cured after that.
Okay. What about other illnesses like Cushing's? Do you treat Cushing's?
Yes, and we're talking about the more rare pituitary tumors first, but those are the ones that are really interesting. Cushing's is typically caused by a pituitary tumor that makes too much ACTH. ACTH is a hormone that stimulates the adrenals to make cortisol. And when the adrenals make too much cortisol, people get a classic appearance where they gain weight. It's mostly central. Their legs are skinny, but they have a lot of abdominal weight. The face can get round and puffy and red, plethoric we call it. People can get little telangiectasias of the skin. They lose a lot of muscle but gain fat, so muscle weakness is a common symptom of Cushing's. Most people, though, that have Cushing's have it from exogenous use of steroids, which, as we know, that means we make them have it by giving them too many steroids to treat other other diseases. But that's another interesting pituitary tumor that's kind of rare. The most common pituitary tumor is not hormonally active. It's one that we just see on a scan. It's not making any hormones, and usually they're very small in the millimeter range, and nothing has to be done about them. But another tumor that is pretty common is called a prolactinoma, and that's when a tumor of the pituitary makes too much prolactin. That's the milk letdown hormone in women. In men, the primary symptom is erectile dysfunction. And as you know, men don't like to admit that, so it may be present a lot longer before it comes to medical attention. But women get breast milk production, and you know, if it's not related to childbirth, then women are going to complain about that pretty fast.
Right. So would this treatment be the same, like removal of the pituitary tumor?
Well, that is the one pituitary tumor that is best treated medically. If it's less than a centimeter, then we can usually treat it with oral medications. There are some rare ones that grow faster, but most of the time we just treat those with medicine and avoid surgery.
Okay. All right. Well, what else do you treat? What about the adrenals? Can you talk about that a little bit?
Yeah, there's a lot of misinformation about the adrenals these days. If you Google adrenal fatigue, you'll see hundreds and thousands of articles, and a lot of them aren't even true. There's just there are a lot of people making money on supplements, and many of the supplements are not FDA approved. They're not regulated. What's in one bottle may not be the same as what's in the next bottle. So I really try to steer people away from that diagnosis of adrenal fatigue, because it's not really an accepted diagnosis by the American Association of Clinical Endocrinologists.
Okay, so there's no such thing as adrenal fatigue. There's no
Right.
such thing.
You're right. That's the best way to put it. There is no such thing.
Okay, so all the supplements that we see, like over the counter, they're not doing anything, because there's no such thing that they're claiming to treat.
You're exactly right.
Okay.
I mean, there are so many, we call them nutraceuticals.
Okay.
Nutraceuticals are supplements. A lot of people say that they're natural, and people think that natural always means that it's healthy, but there are a lot of natural substances, as you know, that are even dangerous. And so when we don't know exactly what's in the bottle, and we don't know that one bottle that says something is the same as the next bottle that says something, we know that there are a lot of unknown side effects and potential drug interactions from those things. So I try to get people to go to what is the root of the problem. What are your symptoms? If you're tired, why are you tired? And let's not automatically say it's the adrenal glands.
Okay, so what exactly does the adrenal glands do?
The adrenal glands make cortisol, which is a stress hormone. They also make some other hormones that allow us to maintain our blood pressure and sodium and water retention, and also some sex steroids that are like the hormones from the ovaries and testes, but just smaller amounts.
Okay. And what about sometimes when you get a CAT scan of the person's abdomen for like another reason, and there's incidentally like an adrenal adenoma or a tumor on the adrenal glands, and the patient may not have known it? What do you do for that?
That's a great point. We call those incidentalomas, and they happen everywhere. Almost probably 10% of the population has an incidental pituitary tumor. About 10% has an incidental adrenal tumor.
Okay.
And incidental thyroid, and when we say tumor, I'm talking about benign tumors. But they're very common, and the more we look with tests, the more we're going to find. And then we have to decide, what are we going to do with this? Does it really need to come out, or does it need to be evaluated, or could that person live the rest of their lives without it ever causing a problem? But with the adrenal gland, we like to, again, see if it's hormonally active, just like with the pituitary. Most hormonally active tumors of the adrenals will cause hypertension, high blood pressure. So we assess when they develop hypertension. Was it sudden onset? Has it been a long time? Do they have a family history of hypertension? What's the potassium in the blood? Do they have any symptoms of headache, palpitations, sweating, all those different things that would make us think that it might be a so-called secondary cause of hypertension, which means something that we can treat, an identifiable cause.
Okay, so if they do have an incidental adrenal adenoma or tumor, and they do have high blood pressure, then what will be the next step? Would you remove the adrenal tumor, or?
Well, if they have high blood pressure and it's caused by the tumor. A lot of people will have hypertension and an adrenal tumor, but it's not related. But if we find that it's hormonally functioning and it is causing or contributing to the hypertension, then it should come out. And there are surgeons that are skilled in taking the adrenal gland out laparoscopically, so it's less invasive and a lot less of healing and a problem than an open surgery. So that is the treatment. But the other thing we have to think of is adrenal cancer, and the risk of cancer in an adrenal nodule is greater the bigger it is. So if it's 5 centimeters or more, we tend to think, wow, that might be cancer, so we would be much more likely to have it taken out. So, but a lot of times we just follow them with scans, make sure that they're not hormonally secreting, and just follow them over time.
Okay. So if they do have it removed, do you think that would give them any symptoms?
Well, most of the time the other adrenal gland takes over.
Okay.
So just people can live with just one adrenal gland, and if the tumor is causing symptoms, then yeah, the tumor, removing it would alleviate the symptoms.
Okay, great. Okay. What about the parathyroid glands? What type of problem can go wrong with the parathyroids?
Well, hyperparathyroidism is very common these days. I just see it all the time, mainly because we look for it. But the most common cause of hyperparathyroidism is due to chronic renal failure. When the kidneys stop working, the parathyroids sometimes put out more parathyroid hormone to try to compensate for the lack of vitamin D production and those types of effects that affect calcium metabolism and bone reabsorption and things like that. So we see that a lot. Sometimes we just treat them with vitamin D or activated vitamin D. Another cause of hyperparathyroidism is secondary just to vitamin D deficiency, because as you know, that's pretty much an epidemic in our society. It's hard to get enough vitamin D in our diets. A lot of people don't get enough sunlight. So just treating the vitamin D deficiency can resolve the hyperparathyroid problem. But sometimes it's due to hyperparathyroidism is due to just one benign adenoma, and in that case it needs to be removed surgically, and we send people to endocrine surgeons for that. If we don't treat it, the calcium can get too high. People can get osteoporosis, they can get kidney stones, and just generally feel bad, depressed, tired, things like that.
Okay. So is that usually found incidentally, or are people having symptoms with the hyperparathyroidism? Is it like routine blood work that finds a high calcium level?
That's exactly right. It's usually found with routine blood work because we get a calcium with most of our basic metabolic panels.
Okay.
And so the key thing to look for is just a high calcium in the blood. And then if that's elevated, then we usually check the parathyroid level and see if it's high, see if that's what's causing it.
Okay. So if you have high calcium, it's usually hyperparathyroidism. So if you have low calcium, is that hypoparathyroidism?
That's right. Hyper means too much, and hypo means not enough. Hypoparathyroidism is not as common, and typically that's caused by a thyroid surgery where the surgeon unfortunately took too much stuff out of the neck, and they can sometimes take the parathyroid glands by accident because they're so small, and that might happen if somebody has a big huge goiter, or if they have invasive cancer and the surgeon has to do a lot of dissection in the neck. So if somebody gets that, then we typically we have to treat them with a lot of calcium and a lot of vitamin D to avoid seizures and muscle problems and things like that.
Okay. So it usually doesn't just occur on its own, the hypocalcemia or the low calcium?
It can from just autoimmune attack, just like the body attacks the pancreas, the body attacks the thyroid. There can be just plain autoimmune hypoparathyroidism, but more often than that it'll be surgically induced.
Okay, and then you just take the calcium to treat it usually? Okay.
That's right.
Okay. Well, great. Well, what else do you treat? I think you treat osteoporosis, I believe?
That's right. Endocrinologists do treat osteoporosis, and as you know, that's another very common problem in women as they age. And after menopause, we tend to lose bone very rapidly, and women are living, well, men and women are living so much longer in our country that if you live long enough, you're probably going to have some degree of osteoporosis. The risk factors are low calcium diet, not enough exercise, alcohol, smoking. There are some genetic factors that lead to osteoporosis, and a thin build. So that's one reason to have a little more meat on your bones, is it protects against osteoporosis.
So what does osteoporosis mean for people who don't know what it means?
Oh, right. That's where the bones get kind of weak. They lose some of the calcium. They lose their internal structure that makes the bones strong, and it makes the bones sort of brittle, so that that a person would be at risk of a fracture. And some fractures are pretty bad. A hip fracture, it carries about a 50% mortality rate, and that's because someone would have to be at bed rest, and they're more likely to develop pneumonia and urinary tract infections and maybe a heart attack, stroke, things like that. So that's a very important thing we need to try to prevent, is a hip fracture.
Right. So like after a hip fracture, a lot of times things just go downhill.
That's exactly right. Yes. Other common fractures are the vertebra of the spine, and then the wrist sometimes too.
And do you ever order a bone density scan?
We do that a lot, yeah. About once. Most insurance companies will pay for it about once a year, sometimes every 2 years. But that tells us the density of the bone and what a woman's bones looks like compared to the young adult peak bone mass, and then it compares to other people her age.
Okay. Is there a certain age when you start screening with the bone density scan?
Well, I usually base it on the woman's risk factors. If she has a problem such as hypoparathyroidism, that's a risk factor. Hyperthyroidism is a risk factor, and all those other things we just mentioned. So I would do my first screening test probably right after menopause if they don't have those risk factors, but maybe earlier on if they do.
Okay. Was there anything else that you treat? Because the first episode we talked about diabetes and thyroid problems, so we had to come back and do part 2. Okay, so is there anything else?
Well, we certainly treat a lot of obesity and insulin resistance syndrome. Insulin resistance syndrome, as you know, is a pre-diabetic state. So we not only treat diabetes, we try to prevent people from getting diabetes. We treat a lot of heart disease just by risk factor modification. We treat cholesterol problems, hypertension, all those things that might lead to heart attack and stroke. Okay,
well, let's talk about the pre-diabetes. I don't think we talked about that before, the insulin resistance. So what's the patient look like, or how do they end up in the endocrinologist's office?
Well, that's very interesting, and I really like to see people at that point, because we can do so much to prevent problems. But the typical patient will be obese. As a young girl, they might have something called polycystic ovarian syndrome, and girls get irregular periods or lack of periods. They get the central fat storage. They get acne, hair growth on the face. Sometimes they have infertility, and that's just all associated with a huge risk for diabetes. And if they get pregnant, they're at risk for gestational diabetes. So we try to prevent it by getting them to lose weight, and people don't have to get to ideal body weight. We try to get them to lose about 10% of total body weight. So if someone's 200 pounds, that might be just losing 20 pounds and maintaining it. We also put people on metformin, which is a medicine for diabetes, but it does show that it helps reduce the risk of diabetes.
So are there particular blood tests that you will order to see if they're insulin resistant?
There are some tests, but you really don't need to order anything fancy that costs a lot of money. You can really just look at the patient and see if their fat is stored centrally. That tells you that they are very likely to be very insulin resistant. And so you can do a waist to hip ratio with a measuring tape, or you can just look with your eyes. And you know, there are some criteria that we're supposed to use to officially call it metabolic syndrome, but I think most of us know just by looking, and you just see a classic type patient with an elevated so-called gut to butt ratio. And if that's the case, then and family members look very much the same like that, and you know, if the family member has diabetes and other people look like that, there's a strong chance they may get diabetes. So there's not one particular blood test, but we do look at thyroid function, lipids, we look at the blood sugar, things like that, and just start trying to modify risk factors early on so that they don't develop it.
Now, when you give them the metformin, are you giving them the metformin even though their glucose may be normal, or is it already high in the pre-diabetic state?
No, we give it to them when the blood sugar is normal, and it will not lower the blood sugar too much. Most of its effect is on the liver, and it does not increase insulin levels, so people will not get hypoglycemic on it. They won't get a low sugar. In fact, some people that get low sugars just when they eat a lot of sugar because the pancreas is overworking, it can help reduce those episodes where they feel weak and shaky.
Okay, well, that's very interesting.
Yeah, there are other strange endocrine tumors that cause various syndromes, but what I really like to treat is bread and butter diabetes and thyroid and things that affect most people, or so many people in the population.
Yeah, well, that sounds good. Yeah, let's see. Is there anything else you can think of that you treat?
Well, let's see.
What about hypoglycemia? You hear a lot of young girls saying they're hypoglycemic.
Yeah. Well, you know, the diagnosis of hypoglycemia is another one of those, I call them sort of voodoo diagnoses, where it's probably overdiagnosed, probably like fibromyalgia or EBV, you know, chronic fatigue syndrome, things like that. I think that hypoglycemia is kind of the endocrinologist chronic fatigue syndrome, and a lot of people think they have it, and they may have symptoms of it, but we can't really call it hypoglycemia unless you have a blood sugar that's documented by a lab to be below 80 and associated with symptoms of hypoglycemia, which would be rapid heartbeat, confusion, shaking hands, sweating, hunger, things like that. But the most common way that I see it is what we just discussed, where somebody is obese, they have insulin resistance, the pancreas is still working well, and it shoots out too much insulin when people eat, especially a large carbohydrate meal, and then that causes the sugar to bottom out. And the best way to avoid that is to eat meals that are mixed with protein and fat, not just simple carbs, and eat more complex carbohydrates, so there's not such an effect on the insulin levels.
Okay, well, that sounds very interesting. It sounds like you see a variety of patients.
We do have a wide variety, and you know, we talked about diabetes before, but we have so many different treatment options for diabetes now. There are probably about 12 different non-insulin drugs on the market now. So we have pills, we have injections, we have insulin pumps, and then they're all different types of designer insulins. We have continuous glucose monitoring, where people can wear a sensor and look down and see what their blood sugar is all day long. So the treatment of
diabetes. Can you talk a little bit about the non-insulin injections that are out? I don't think we discussed that on the last show.
Yes, and these are drugs that I love to talk about because there is not much of a downside at all. These are drugs that work on two main hormones in the body. They increase insulin and they decrease glucagon, and that has the effect of lowering the blood sugar. But the good news is that they do not cause weight gain. In fact, they help people lose weight, and they don't cause low blood sugar, hypoglycemia, and those are the two main complications of any diabetic treatment, are weight gain and hypoglycemia. And so the patient, of course, loves it, that you can tell them you're going to lose weight even if you don't diet and exercise, but we want you to diet and exercise, but still your diabetes meds will not be going against you and trying to put weight on your body. So those are really nice drugs. They are injections, but the needle is extremely tiny, and you can hardly even feel the needle, and most people don't have a problem with giving the injection because you can hardly even feel it.
And how do you know when to give that? Is that when the pills don't work? Is that when you turn to those type of injections, like in a type 2 diabetic?
It's just another tool in the toolbox. Metformin is the most common first-line treatment because it's very cheap, it's safe, it's been around for a long time, and most insurances will cover it no problem right off the bat. All of the other drugs are typically our second and third and fourth add-on drugs, and basically we just individualize the treatment, looking at their situation, what they're willing to do, how old they are, their lifestyles, whether they're a truck driver or they do something else. We want them to, be able to keep their jobs and things like that. And also depending on how much they really want to lose weight. Some people really say, well, there's no way I'm ever going to take a shot of any kind. I'd rather take a pill, even if the shot would help me lose some weight. But so it's just very individualized.
Oh, okay. righty. Well, that sounds good. Anything else you have to say? I think our time is about up. A few more minutes.
I think, you know, what I try to do is just get the patient to be very proactive in their own health.
Okay.
A lot of people come to an endocrinologist thinking that there's a magic pill. They bring tons of bottles from the health food store. They think that other doctors, you know, maybe have messed up their thyroid or aren't giving them the right thyroid hormone supplement. And what a lot of people need is, you know, very simple: more exercise, more stress reduction, less alcohol, you know, all kinds of things like that. And I try to get people to think more about those, because people can waste an awful lot of money on bottles of pills and supplements, and most of the time people need to take in less rather than take in more, especially out of a bottle. And it costs some money, and you know, like I said, a lot of that is, nutraceuticals in general are not FDA approved, and they can be dangerous, but at least a lot of them are a waste of money.
What about the ones like, I've heard people ask me questions about these things over the counter, like the nutraceuticals that you're talking about, but they're some type of testosterone booster?
That's another situation where I don't think there's a lot of clinical evidence or scientific evidence to show that these things actually boost testosterone levels. And then another very controversial subject is hormone replacement therapy in women. And a lot has been written and said about bioidentical hormones. And bioidentical hormones are substances that pharmacists compound, and they say they look exactly like our own endogenous estrogen, but often they don't look exactly like our own estrogen. The other thing is these hormones can have some very bad side effects, and of course with diabetes we always worry about heart disease and stroke, and estrogens likely do increase the risk of heart disease and stroke, but it depends on how old the person is and their other risk factors. But I try to steer clear of female hormone replacement therapy, especially in older women, unless they're right around the menopause and they're having excruciating hot flashes. In that case, we're taught to use it at the lowest dose we can and for the shortest period of time we can. But there's worry about the risk of breast cancer, the risk of uterine cancer, ovarian cancer, things like that. So it's just not a straightforward story, you know, in most women.
Okay. All righty. Well, you've been so informative. Thank you so much.
Well, thank you for having me.
Thank you so much. I really appreciate you coming by. I've learned a lot, and I'm sure the audience has learned a lot as well.
Well, we packed a lot into 30 minutes.
That sure was a lot. Thank you so much. You have a great day.
Thanks.
Bye-bye.